Good evening. Okay, I'm going to try to do this without glasses on today, so if you see me squinting, I really should have glasses. So, good evening and welcome to the University of Findlay. We are delighted that you can join us for the 14th annual Evening with a Leader. The faculty and I look forward to this event every year, and we are pleased that we have been able to continue to offer high-quality continuing education at no cost to you. But before I introduce our speaker, there's a couple individuals that we need to acknowledge tonight. But the first person is Rachel Darrow. And I said her name right, so that was good. She is the Assistant Alumni Director, and she is here to give our alumni a special welcome. Sure, I'll hold the basket too.
Cool. Great, thank you. Good evening. Welcome back to all of our alumni. Thank you, Mary Beth, and the occupational therapy faculty for asking the alumni office to take a minute to recognize our wonderful OT alumni. So if I could ask all of our OT alumni that are here tonight, if you could please stand, we'd like to recognize you. Yay. We are really happy to have you here tonight, so thank you very much. This is your university, and we welcome you back often. We do value your relationship with your alma mater, so thank you. I would like to take a few moments to share some of the exciting things available to our alumni, especially for the current students in the room, things to look forward to. If you are a graduate of the last 10 years, you are a member of our Generation Orange family, and we would love to hear from you and get you involved with Generation Orange. It is growing rapidly, and there are a lot of exciting things coming down the road, so if you are interested, please feel free to contact our office because we'd love to get you plugged in. In January, we did launch our free virtual book club to everyone, so it's open to students, public, alumni, and the like, and if you love to read, we'd love to have you join us. Save the date for Homecoming 2018. It will take place October 5th through 6th, and we hope to have all of you back on campus to celebrate with us. Lastly, on the tables out front, we do have our event cards that list some of our upcoming events, and all are welcome. There are additional events listed on our website as well, and you can register online. Also on our website, we have our Share Your News link. So whether it's to simply update your contact information, a career update, a birth or marriage announcement, we want to hear from you, and so does the OT department. So please go on there and update us, and we can share it with the OT faculty, and we also like to recognize that in our Findlay Mag, which is our alumni magazine, and share your updates with your classmates. So that's all of my announcements. I just want to announce our door prize winner. So if you got a ticket, alumni, as you came in, let's get that out. Okay.
What's in the bag, do you know?
Oh, it's what's in the bag? So it is the Oiler Nation Shirley's Gourmet Popcorn, which is delicious. There's some chocolate-covered pretzels. Dietzes. And Findlay colored, of course. There is some Findlay mints and a pack of greeting cards. And our winner is ticket number 4324734. Yay! Come on over. Well, thank you again so much. Thank you, alumni, for being here tonight, and I hope you enjoy your evening.
Thank you. So if you saw me giving eyeballs to the faculty up here, all I have to say is alumni and current students, you need to represent OT on October 5th and 6th because the OT faculty will not be here because we will be celebrating Professor Meredith's wedding that weekend. So please represent us well, okay? Thank you. You got to take care of it, OT people. Homecoming, all that good stuff, right? Okay. So this event is made possible by the hard work of a number of people, especially the two administrative assistants for our program, Amy Eater and Kathy Hawkinson. We would not be able to do this without them, and they're still manning the tables out there. So if we could kind of give them a round of applause. The event continues to grow. As you see, we've had two this year, so it was pretty busy this year. It grows so much that we now have a dedicated committee to be able to put forth and get this event running. So this year, our committee was Cindy Goodwin, Rebecca Hare, Lisa Sake Miller, and Miranda Tippie. So I would like to thank them for the work that they did to make this night a success. I'd also like to recognize the rest of our full-time faculty team and our part-time instructors and lab assistants. I would ask them to stand, please. Come on. You are faculty. We also have had, in the last month, we've had a appointment of our new Dean of Health Professions, and his name is Dr. Richard States. Unfortunately, he could not be here this evening. He was double booked, as he now finds himself quite a bit being double booked. So we like to acknowledge him, though, even though he's not here. The other members of our educational team include our clinical fieldwork educators. If you've been a fieldwork educator for one of our UF students ever, please stand. We cannot do it without you. We appreciate it. And Heather Meredith is here, so if you have this burning desire to be a fieldwork educator, she's right here. She'll give you her business card.
I have a student for you.
I would also like to acknowledge our very own awesome Make Mama Proud students. If you're a current student in the University of Findlay OT program, please stand up. We love you. We love you all. We also acknowledge that there are other OT and OTA schools that make the trip to come see this event every week or every year, so welcome to our home. We would like to welcome every week. Oh my gosh, wouldn't that be a mad? Yeah. So a few housekeeping items. Please turn off your cell phones. Okay. The restrooms are located they're on all three corners. If you do have to leave, we ask that you exit through the back door, or we'll watch you leave, so if the back doors are great. So now on to talking about our speaker. I have been blessed this year to have been chosen to participate in the AOTA Academic Leadership Institute. As a part of the experience, I attended a 2-day workshop this past summer that provided mentorship from several of our past Evening with a Leader speakers. During this workshop, I was sitting in the hotels, as you sit in those workshops, and we had a panel of mentors, which included Florence Clark, Neil Harbison, we won't tell him I said his name, Amy Lamb, and Dr. Burke, who spoke to the group. And as I was sitting there, I was looking, and I'm like, they've all been there, except for Janice. So I decided during that workshop, because of the mentorship that she had already provided and the things that she was saying that weekend, that we needed to bring her to Findlay to share her knowledge with you. So I've learned a great deal from Dr. Burke over the last year and have cherished her mentorship, and I really am excited that she's here to share her experience with you in Findlay. Dr. Janice Burke was the Dean of Jefferson College and Health Professions at Thomas Jefferson University from 2006 to 2015. She joined the university in 1988 as an assistant professor and later became director of graduate programs, chair, and professor. Dr. Burke is credited with leading the Department of Occupational Therapy from unranked to its current status as 6th in the U.S. News and World Reports. She's collaborated in establishing a Jefferson Elder Care, an OT service for individuals with Alzheimer's disease. As dean, she was responsible for overseeing 7 academic departments, including developing the couple and family therapy and physician assistant programs. Dr. Burke is nationally recognized for her expertise in providing OT to young children and their families, and her publications addressing the health-producing effects of occupation in individuals with chronic disabilities and the well population. She co-authored The Model of Human Occupation, a contemporary perspective in the field of occupational therapy, which has driven education and research and practice over the last 35 years, and which our curriculum is built on. Yay! In addition to her work at Jefferson, Dr. Burke has served on national boards, including the American Occupational Therapy Association and the American Occupational Therapy Foundation boards, and chaired the National Academic Leadership Council from 2009 to 2015, which is the first time I was actually exposed to Dr. Burke. Dr. Burke has served as a panel chair and scientific reviewer for the U.S. Department of Defense. She has a record of over 15 years of continuous funding from the U.S. Department of Education for training OTs to deliver care to preschool and school-aged children. Most recently, she developed and now leads the AOTA Academic Leadership Institute, designed to provide key leadership skills to faculty, program directors, and department chairs. Recognized for her achievement, Dr. Burke has received the Lindback Award for Distinguished Teaching, Burlington Resource Foundation Faculty Achievement Award, AOTA Eleanor Clark Slagle Award, AOTF Aging Heirs Award, and numerous service commendations. She is also a fellow of the AOTA. Tonight, Dr. Burke's presentation title is Productivity, Outcomes and Evidence in the Clinic, Protecting the Future of the Therapeutic Encounter. We are super excited that she's here. Please help me welcome Dr. Burke.
Hi, everyone. It's so nice to be here. Okay, so this is going to be kind of wacky. I'm going to do 3 different things here tonight. I'm going to start with some polling questions and just ask you to raise your hand, and I'll give you in response to the questions, and I'll give you a feel from my point of view of about how many people I think are answering the questions. Then I'm going to go into talk about outcomes and productivity and evidence, and kind of look at what the state of it is right now in terms of the pressures we're feeling and some of the responses I think that are already available to us. And then the third part of the presentation is going to look at the verbal and nonverbal behaviors that constitute the therapeutic encounter. And I want to spend some time on that because I think that might be an area that you'll want to think about as you move into a systematic approach of looking at how your treatment is affecting the patients that you work with. So, and I also wanted to spend some time just talking. I hope that you'll generate some questions, so I'll try to stay on time with this. So I can't see the clock. So I just need to know, Rebecca, like when 30 minutes go by every 30 minutes. So, okay. I didn't time this, because how do you time a 2-hour talk? So, all right, just to begin with, so I just want to know from you, do you use the term outcomes to explain occupational therapy with the patients, families, or referral sources that you work with? How many people say they use the word outcomes all of the time? Okay, no response. Some of the time. Okay, that's like 1/8 of the group, and never. It's for everybody else, right? Okay. Oh, and some of you aren't working, I understand that. Okay, so here's the next one. Here's the next one. But that's the same one. Oh. I might have turned it off. Wait, how do you turn it on? It's an on. Okay, thank you. Oh, good. Okay, so then do you use the term outcomes to explain a specific occupational therapy plan? Go back. Two, yes, please. To explain a specific OT plan, treatment, intervention. Okay, so I'm going to assume about the same, right? Does anybody use outcomes for that, all right? The next one, thank you. Okay. This is hard to be this coordinated. All right, 3. I should have started by telling you that if it can go wrong, it will with me. Do you provide outcomes data when you meet with patients, referral sources, to set up a treatment plan? Anybody? couple of people, okay? So this is foreshadowing where we're going to be going with this, because to me, this is like where it's going, OT is going. 4, do you use specific information about outcomes to select an assessment, develop goals, or measure patient progress? How many people would say all of the time they use specific information about outcomes? Okay, good. So some people say yes. Do you use AOTA's CATs? Does anybody use their critical appraisal topics to collect evidence for their assessment or treatment? Yes? Yes? No's? Okay. Who does not know about them? And who does not have the time? All right, okay. Have you been in an administrative or staff meeting or a conversation where the issue of productivity has been discussed? All right. Have you been in an administrative staff meeting where the outcomes have been discussed? Fewer, but still. Where evidence-based practice has been discussed. Yeah, see, so it's leaking into practice, these words. Do you think what do you think should be measured in an OT session to truly capture the unique contribution that OT makes? So I want you to think about that. I want you to think about that as we move along, because possibly by the end we'll have time to talk about this. But what about OT is so special that we could document it and prove our value? Okay, and the final question is, have you been in situations where OT has been squeezed out of a clinical service? Anybody been in anything where they've been squeezed out? A few people, yeah, okay. Squeezed out because, yes, because another profession provided evidence, and no, but the conversation has come up, show me the evidence, right? So, okay, so those are our polling questions. Okay, so now I can move to the next PowerPoint. So I will say that I recently was treated for vertigo. Has anybody ever had vertigo? It is so weird. You just get dizzy. I got dizzy like if I laid down on the yoga mat and came back up, I got really dizzy. I got dizzy at the gym when I did bench presses. My trainer thought I was just trying to get out of it. I went to PT. Oh, so I went to my doctor. I said, you know, I'm dizzy. And she said, do you have vertigo? But it has a much longer name than that. And I went to the PT, and the PTs gave me 3 sheets of paper that told me what the condition was, how many people had it, how many people get better using what strategies. Okay? That's what's going on in the real world. I think if anybody's been diagnosed, if anybody has anyone in their family who's been diagnosed with any kind of a disorder, you get paper that tells you about the evidence, that summarizes the evidence for you. Okay, so 80% of the people that get vertigo recover in 3 to 5 PT sessions. And 20% have a chance of getting it again once you've had it. And it can come from, and they tell you exactly what it could come from. It could come from, which I like to think, chronic sinus and ear infections. I'd like to think it was that. It could also come from a concussion, and it also can come from age. Therefore, that's why I chose the first one. Okay, so let's talk a little bit about productivity, outcomes, and evidence. And what I really feel is very important, which is protecting the future of the therapeutic encounter. Because I think that what goes on in therapy truly is, in occupational therapy truly is important and is what has a key ingredient that helps people resume the kind of life that they would like to have. All right, so the next slide. part one. Pragmatic consideration. So I just want to get down to, like, let's get down to the nitty-gritty about what's going on here. Okay? And the next one after that, okay, is this is OT's Vision 2025, right? Which we all sort of have to get on board now. After that, what was the other one? Centennial Vision. Right now we're getting on board on the 2025, which talks about health and well-being, quality of life. Quality comes up a lot in the literature about productivity and outcomes. And of course, then efficacy comes up, okay? And our shtick is about participation in everyday circumstances. Yeah, I'll get it eventually. I know Florence must have had trouble with this too. And so here are the pillars. The vision is built on 4 pillars, and I think the terminology is really interesting with the pillars. It's about effective, it's about creating leaders, it's about being collaborative with clients to produce effective outcomes, and it's being accessible and culturally relevant. Okay, so these are words that when you start looking at the literature on outcomes and productivity, you see repeated over and over. These are some of the key words that came out of the statements by Hildebrand, Young, and Stover. Does everyone know who Hildebrand, Young, and Stover are? They were just elected the AOTA president. Hildebrand, Young, Deborah Young is our vice president, and Stover is a board director. We just voted January 31st. And these are the things that were in their statements: value-based, quality care, population health, evidence-based, quality outcomes, and policy and practice changes that are science-driven. So this is clearly where we're going as a profession. Okay, so let's talk about productivity and what productivity is. And when we're talking about productivity, we're talking about service delivery models, productivity standards, practices, methods, and they have to be reasonable. But this is really your administrators. These are the people that are running the clinics and the hospitals, and who are looking at the bottom line. And for them, this is what they care about. What service model are you using, and what kind of productivity do you have? And there was something interesting. There was something recently in the OT practiced in December 2017. Some of you may have seen it, December 17th, about productivity values and the ethical issues that come up with them. And I think we've all probably really faced them. But we have to understand that it's the job of the administrators in our institutions, in our organizations, to be looking at what kinds of services should be purchased. How much money should they be spending on OT, and what they get for that service, okay? And they're going to start turning to you more and more, especially given the changes that are coming out of the White House, okay? This is really what productivity is about, and this is right from that article. It's a measurement standard by which most OT services are quantified, and that is reflected in the workload expectations. So when we do the math, in order to pay for turning on the lights and your salary and your fringe benefits, a certain productivity has to be attained. So it's an expectation, it's black and white, it's numbers, it's quantifiable. And it also has to do with functional outcomes. So how much do you get? How much can you prove that the patient is performing? And how many units of service does that warrant? Okay? And again, it's driven by the need to ensure that there's the appropriate amount of staffing that the maximum reimbursement is going to be able to be achieved, and that the place you're working is going to be able to have economic stability. It makes sense. But it's a tightening of the organization. And I was telling Rebecca on the way here, I think I was telling her, when I went to OT school, when I graduated, I worked in a rehab setting, and there was no, it was when I went to OT school, it was the 12-week affiliation. There was somebody there in the rehab center that was there the entire 3 months. And it was a man in a wheelchair who had a lower extremity amputation. And he was waiting for his pylon. And then after that was fitted, he was waiting for his prosthesis. And he was there when I got there, and he was there when I left, inpatient. Now, granted, that was a long, long time ago. None of you were born. But your parents. So that's, you know, this is how much it's changed, right? Now, I have a friend whose child had brain surgery and was literally, it was an outpatient procedure. They were home that day. So outcomes have really, productivity has really changed. So too have outcomes. And outcomes really are about making a difference, showing a change, okay? That's what outcomes are about. Improving health literacy, improving fine motor skills, improving ADLs, that's what an outcome is. And the question is, you know, what kind of outcomes do we think we can do the best? And who do you think that benefits the most from outcomes? And that's where I would start if I was you, wanting to systematize my treatment strategies. I'd start with, when I think about it, who are the most likely suspects to do well with an intervention? Okay, and of course, you know, the medical community research focuses on standard metrics related to survival and physiological outcomes. But in patient-centered outcomes, we also focus on factors that are important to the patient, such as quality of life. And this is where we are achieving payload. Would that be the right way to say it? This is where we're having payload. Because now that we're in a patient-centered environment, we have people who we can ask what they want to achieve. And many of the things that people want to achieve are things that OTs like to do. All right, and then finally, the third part of the title, evidence-based practice. And you probably know this from your courses. Those of you who took students, you know this as your fieldwork educators. We're talking about the best available evidence. And we're talking about taking the client's perspective into consideration about deciding what's the best thing to do. And we're also taking your clinical expertise into consideration. Okay, so our job then is going to be to identify what is unique about OT. Okay, what can we say and do in therapeutic encounters? How do we conduct the encounter? Is there something about the rhythm and the organization of the encounter? We'll talk about this more. And how can we conduct it so that we can impact the time and the money and the productivity issues? So it's not just about applying a specific procedure, I don't think. I think in OT there's much more effectiveness that's bound up in the interaction, in how we get to know our patients and find out what's really meaningful. So just to go back to my vertigo experience, the PT really didn't ask me very much about what I did every day. She didn't know who I was. She, in fact, was perfectly comfortable with me coming in the second and the third and the fourth visit and seeing any of the PTs that were available because they were all good, as she said. But we don't do that in OT. We develop a relationship with one of our patients and we keep them. right? And they come in because they are going to see us, each of us. So I think there's something very uniquely bound up in that interaction that I want to pay attention to today. And that's the therapeutic encounter. And I'm suspicious that it has to do with verbal and nonverbal interaction. So I want you to be thinking about the things you say and do during an encounter with a patient, all right, and their family. All right, so my question is, where did the evidence outcome push start and why is it escalating? And so, here are some of the, pragmatic reasons, right? The rising cost of healthcare, the push to contain spending, and the competition from other health providers, right? Sometimes it's hard to get even clinical rotations because there's so many other providers in the room, other students in the room, from nursing, from social work, from psychology, from PA, right? So that there's a lot of competition from other providers. But I think another reason is that we love data. We're living in a society now that absolutely loves data. It's a data-driven world, and so I thought I would focus briefly on one of my favorite topics, diets. And I think it's ironic about the U.S. News and World Report, because even they have, just as they rank schools, they also rank diets. All right, and what is the best diet? And you see this all the time, right? Even if you tune into Good Morning America, which none of you do because you all go to work in the morning. But when you're retired, you tune into Good Morning America. And there might be a segment on this, all right? So the questions are, which one's right for you? And there are all different to choose from, and they customize them so that, we can look at, well, it's food for you, it's exercise for somebody else, it's healthy eating, it's packaged meals, it's calorie counting, it's, right? Everything, all of them are different. And then there's the data. Tons of data about, on which diet you can lose the most weight, comparing the diet plans, rating the diets, right? And it happens for lots of different things. It happens for what kind of phone you have. It happens for what gym you go to. It happens for what car you buy, right? What truck you buy. And so this is, I think, converging on what's going on in occupational therapy and the pressing need that it is presenting to us as a profession to embrace evidence-based practice. We have no choice. Okay, so I guess I'm delivering bad news. The good news is there are a lot of resources for you, and it's a pretty interesting line of inquiry. And this is an old slide, actually, that I incorporated from another PowerPoint, so I'm embarrassed that I chose to quote myself here. But Burke and Gitlin, we talked about the long pipeline between when research is completed and then adopted in the clinic, and it's a terribly long pipeline, and much research is never adopted. So I'm going to, make the pitch for you becoming systematic clinicians and developing your own systems, your Excel spreadsheets, your bar graphs, whatever you want to do to systematize your understanding of what's working in the clinic for what kind of patient, with what kind of dosage, how many times a week, for how long, okay? And it's led us, to understand how important it is to value this in training, and that's why many of you who are in school now are learning this. But we're also finding out that practitioners really want to learn about this, and that it's worth it to develop all kinds of programs to get this information out to people. So I'm going to, these are some of the barriers that people say. This is kind of old data. This is Alan Jetty, who is a guru at the Boston Research Center. And he cites these barriers, which I don't think are so out of date anyway. I think the size and complexity of research bases affect us. I think that there's poor access to evidence. I think there are organizational barriers, like maybe you don't have internet access where you work. I think there's a lack of expertise to assess validity, conflict with client preferences. They just don't want that kind of treatment. It's hard to generalize the findings to your population, and you have limited time to retrieve, interpret, and apply to clients. So, and I think that, you know, some of these databases or some of these studies have been done on specific cohorts that may not meet the needs of those of you who are in Ohio, who have a distinct group of people that you work with. So I'm really going to, you know, continue to urge you to think about what will work for you. And so I'm going to ask you, you know, is there evidence? Where is the evidence for OT? And I'm going to talk to you a little about understanding and using the CATs, the critical appraisal topics that are available through AOTA. And then I'm going to talk to you a little bit about your clinical practice, okay? So just to begin with, this is what it looks like on that page. Has anybody ever seen it? Right? It's really easy. Well, it's not that easy to find. I don't find anything easy to find on the AOTA.org, but I didn't say that. Is this being recorded? No. I don't find it so easy. I mean, ultimately I have to type in critical CATs. It's capital C, capital A, capital T, little s. So the critically appraised topics are work that others have done for us. Very discrete topics, you see them down at the bottom, children and youth, mental health, you know how we always have those key topics. And they have looked at very specific research questions in the critically appraised topics. And they, you know, tell you how to navigate like you would go to where the red box is if you wanted to look up whatever that says. Thank you. Thank you. Okay, and so so then they give you some very specific ones. This one I chose because I knew Jacqueline Chamberlain was going to be here on feeding, right? And what they look at a specific group of articles, and they rate the articles in terms of the kind of evidence it is, whether it was from a clinical trial or whether it was from, let me think, level 1, level 2, level 3. Clinical trial, randomized controlled trial, systematic reviews, whether it was from cohorts, whether it was a one group, non-randomized. So they tell you, you can believe this because it's high level of evidence. You can take this and use it. It's a medium level of evidence. Or you can go along with it, but it's not strong evidence, all right? It's laid out for you in incredibly specific detail, useful detail. So I just want a show of hands from everyone that promises that, what day is today? Thursday, by the end of the month, you promise you will visit this website at least once. Okay, all right, okay, great. Thank you. And the critically appraised topics are always a focused question. What is the evidence for the effect of using jaw control to improve feeding? There's always a clinical scenario that's given. Third, there's a summary of the key findings. That's where they say, you know, a certain amount of these studies were randomized controlled trials, and this is what they show. The fourth is they have this little final section called the bottom line for OT practice. So, you know, how to proceed with this kind of information. All right, so I feel very strongly about it, and I think you can find it to be very useful. We didn't have anything before we had this in OT. You had to do it yourself if you were interested in finding out about, for example, a feeding intervention. You had to comb the literature yourself. And there's a lot of evidence in the literature. If you go through AJOTS, there's a lot of evidence. Jane K. Smith produced a tremendous amount of evidence at Ohio State, fine motor control, writing, sensory status of young children. I mean, an enormous amount, and she had evidence and outcomes in all of her titles. But before that, we only had something called the Cochrane Database of Systematic Reviews, and that was really a medical model that was used. Got it, thank you, so subtle. All right, so those are the cats, navigating the cats. I thought when I grabbed these screenshots, I thought I was going to do something different with it, and then I am doing. Okay, here's my favorite study, and it's pretty new. And it's higher hospital spending on occupational therapy is associated with lower readmission rates. Have you seen this article? This is a fabulous article. This is really worth having in a special place, keeping this in a special place so that you can go to it when you really need some inspiration. But these people who are not OTs found that OT, it was worth it to spend money on OT while a person was in the hospital because it reduced the chances of them being readmitted. And you know that whole thing about accountable care and how you don't get paid if a person comes back within 30 days, right? The hospital loses money, so of course this is something that the administrators are very, very interested in. And I bring this up because this starts to tease out what our unique contribution may be, okay? And where maybe the data is in our everyday practices. So this has some merit, I think, in terms of where we might want to go with OT. They said that, of course, where we went to before with the slides, that there's the administrative imperative to control spending while improving quality, right? And what they looked at, we were talking about this earlier, the faculty and I, they looked at Medicare claims and cost report data. So you need somebody who knows how to use big data sets to kind of do this kind of study. And they looked at specific service spending and the 30-day readmissions, and they looked at it in those three groups: pneumonia, heart failure, and AMI. And they found that OT was the only spending category where if they spent a little bit more on OT while the patient was in the hospital, there would be a statistically significant association with reduced readmission rates. Isn't this phenomenal? I mean, it's phenomenal. So you have to print this, and you have to bring this to the administrator's office, the finance person, the finance woman or the finance man in your place of work, to show them the hard data. And they thought that really some of the reasons, which I think is just so uniquely OT, is that OT places a unique and immediate focus on the patient's functional and social needs. Okay, we care about that the most. We ask people, who do you live with? Who do you live near? What do you need to do every day? And they realized that functional and social needs are associated with whether or not you will fall, you will become sick again, and you will need to be readmitted. And so they felt that really it was that the patient could be safe in their own environment when they had the help of an occupational therapist. I mean, I think it's really almost could give you shivers. It's about value-based purchasing. It's about increasing the pressure to improve the quality, as I said. And they looked at, lots of patients. They looked at 2,800 people with pneumonia, 2,700 people roughly with heart failure, and 1,500 with AMI. And they realized that the OTs train caregivers in safety and basic needs. I'm preaching to the choir, right? That's what you do. Of course you do that. That they assess the level of a supervision that a person's going to need, and they help them also with health literacy. They help them understand their condition and what they need to do with it, including medical management. And there's one other clue in that they make the link to how important the social aspects of a person's life is. So OTs often look at the social environment that the person lives in, the neighborhood, and how that will permeates the living of older adults. And we know that that's true, right? I mean, when you interview people with older people who are going home, they frequently talk about, I can call my neighbor for that. My other neighbor across the street will do my shopping for me. I have someone from church who will take me to the food store or to the doctor, right? So this social component, we know how to access and we know how to work with. So that's the really good news. These are the reasons why they found social factors. Sorry, I didn't flash that. And they recommended, these 3 people who aren't even OTs, recommended that we could consider doing more of this and working with these kind of people. So they saw others outside of OT saw our value and published it. Okay, I think that's really amazing, amazingly good news. Okay, here's another article that I really love. Home-based care reduces disability and promotes aging in